So we're going to use this as an example of a patient who presents in the clinic with neck pain. A very typical pathology that we'll find would be a unilateral hypomobile C2-3 joint. So that's the example we're going to go with today. This patient theoretically cannot extend C2-3 on the right. And so they could present in your clinic with complaints of neck pain, headaches, dizziness. They could also present with some trigeminal facilitation signs, such as ringing in the ears, lump in the throat, metallic taste in the mouth, cloudy vision, panic attacks, and a manipulation to this area can have a profound effect on the patient's well-being. I mean, it dramatically changes their quality of life sometimes because they think they're going crazy. They have all these weird, seemingly unrelated symptoms. Before we get to the manipulation, though, we have to do a cranial nerve scan and a cervical scan, and we have to stress test the craniovertebral ligaments and the cervical ligaments just to clear for anything sinister. So in this case, we're going to assume that we started with our cervical scan and it was negative. Our cranial nerve scan did not pick up anything, and he has a normal, intact ligamentous system in his craniovertebral region and his lower cervical spine. That's the ideal case. That hardly ever happens in the clinic, but it's a very nice example to use. So we can do an ideal manipulation where we can lock from above and below in this case because there's no ligamentous hypermobility or instability. So before we get on to the actual manipulation, let's talk about the orientation of the facet joints. So in the cervical spine, they sit like this. And as I go to lay down, they come like this. So extension is an inferior medial posterior direction, or an IMP. And this is of the facet joint. And then flexion is a superior anterior lateral, or SAL. So you can call it IMP, SAL, flex, extend, up glide, down glide, whatever you want to call it. I need the joint to close. And my verbiage I use is IMP because it directs me to go inferior medial posterior, and since it's this right joint that can't go, I'm going to direct my force towards that left hip. So we will close down the joint. A few housekeeping details since I'm on the shorter side. I actually position my patients a little bit differently. So go ahead and kind of angle yourself at a 45-degree angle. By standing here, it just gives me less bed that I have to work around. So what I need to do to craniovertebral lock is I come in here and I side bend right, rotate left, which is craniovertebral locking. Then I will extend and side bend down into C2-3. I've got my upper lock. Come in here, and now to lock the lower cervical spine, I take C2 and I translate it across. And this is a good time to do our pre-manipulative hold. So I have him in this position, and I am looking for, I ask the patient, does this reproduce your symptoms? No. And he says no, so that's good. I also tend to ask, does this give you numbness and tingling in your lips? Do your toes feel funny? Just any other medical symptom you'd like to tell me about, just to make sure that I have not missed anything in my diagnostic exams. He says, nope, I'm good. I also look at his eyes, make sure there's no nystagmus, face for color blanching. So all that checks out, I go ahead and release. I held that for approximately 10 seconds, but I go ahead and release. And I say to the patient, all right, so next time we do this, I'm going to lock you up, and I'm going to give you a little thrust there at the end. You might hear or feel a pop or a click. Are you okay with that?
Yeah.
Okay. So we got a verbal consent. We've medically cleared anything sinister that could potentially harm the patient. And as I said, this is the ideal situation where we can lock above and below and just target our thrust right on the hypomobile segment. So what we're going to do, we'll go through that again, is we craniovertebral lock down to and into, and then I go down to and into C2-3. I'm going to translate C2 across, and I'm taking up all the slack in the joint. And if you look where my elbows are, this tells me that I'm on the facet joint. It shows me if I had them in here, it's a lot harder to get the angle, so I keep my elbows out here, and my movement is going to be this. So it's that. This is my thrust hand into an IMP, inferior medial posterior direction, and my counter thrust is coming here. Superior anterior lateral. But emphasis is on this hand, because that's what I need the joint to do. So, craniovertebral, and side bend down to and into. Translate across. And I say to the patient, all right, go ahead and take a deep breath with me. And let it out. And at the end, it's just a quick little thrust. it's really important to time your breathing with your manipulation because it's very hard to get a good high velocity thrust halfway through a breath out. So I have everyone take a deep breath in, let it out, let it out, let it out, let it out, and then it goes. The other thing that you want to do is I provide a little bit of gentle compression here just to simulate gravity. I'm not trying to move his whole body, but by having him here, I can control my lock better and I give a little bit of gentle compression. A good position for your feet to be in is one foot staggered in front of the other, and I tend to lock my arms out, and a lot of my manipulative force comes from my trunk because I'm stronger through my core than I am through my arms. And so once I get him locked down and into this position, my arms remain stationary, and a lot of the movement is coming from my hips. And that helps me maintain my high velocity low amplitude thrust. So I'll show it to you one last time. Go ahead and take a deep breath in and let it out. And there we go.